Okay. Start, sir. Good evening and a warm welcome to everyone. And this is the first I read on like CME, what we are doing after we are taking over by Lanka. And today we are the, although we see less numbers here, Ramesh is here, Dr. Sharma is here, and of course all the speakers. So I would like to, first of all, like you said, first time we are doing this as an hybrid. Let's see how it's done. It's been a long time, it's for 2 years, and face-to-face contact is not there. And we expect more numbers, and hopefully the going forward we should have a good weekend like this. At least for the next 3 months, we would like to have a continuous meeting. So today we are going to talk on non-metastatic prostate cancer. We have lined up almost 4 talks and one day panel discussions. So we'll start up with day one. I invite Shantu to take over and.
Everyone, welcome to the hybrid meet that we are having from AROI Karnataka. Patient oncology, Medical College, prostate cancer, and influence in the management. Wait, Dr. Sharan Krishna will be joining us online from.
Good evening to everyone. Am I audible?
Yes, sir. You're audible.
Okay. Can I start the presentation? Okay. Let me just share my screen. Is my screen visible?
Yes, sir, your screen is visible.
Okay. So presentation is visible, no? Right. Okay. So good evening, everyone. And at the outset, I would like to thank AROI Karnataka for having given me this opportunity. And before I start my presentation, I would like to start with a disclaimer that I have very limited experience in research in prostate malignancies, and I'm more or less an, let me say, end user. I'm a clinician who practices the existing guidelines. So whatever I'm presenting here is basically guidelines that are available in our literature. And with that, I think we'll go to the overview of my presentation. I'll be touching upon what is the importance of risk stratification in prostate cancer. I'll be touching upon parameters that are used to identify what might be the risk of a particular cancer, and then how we risk stratify prostate cancer. And then maybe a little bit we'll be discussing upon the molecular tests that are available, up and coming molecular tests that seem to have a role to play in risk stratification, in prognostication and predictive understanding of management of prostate cancers. And then finally, I summarize the presentation. So why risk stratify the patient with prostate cancer? The thing about prostate cancer is, as we all know, it's a very, very common disease. Excuse me, am I audible? Am I audible?
Sir, you are audible. Share your presentation, sir.
Oh, my presentation is not visible, is it? Okay, let me just do one thing. I will. Is it visible now? Is the screen visible? I can't hear you.
Sir, make it full screen, sir.
Full screen, is it? Okay. Is it now?
Perfect, sir. Correct, sir. Yes, sir. It's perfect.
Okay. Okay, maybe I can see the video from your end, so maybe that will help me if give an idea of whether I'm like presenting correctly or not. So please interrupt me if there is an issue with audio. I'm really sorry I could not join in person. But yeah, let me continue with my presentation. So why should we risk stratify a patient with prostate cancer? One reason is it is a pretty common disease. It's quite frequently seen, especially in older populace. The second problem with prostate cancer is not exactly problem. The observation with prostate cancer is it has a long course, which basically means it can be indolent, it can be aggressive. There is a lot of variation between individual patients. And then the third reason for that is we have the know-how to identify the disease early. I mean, it is a test that is amenable, a disease that is amenable for screening. So as a result of these three, there is a huge amount of heterogeneity in prostate cancers. There can be something very less aggressive and something very aggressive, all hidden in one particular this one. So as an example, just if we were looking at histology, it would all look the same. But in that histology, you might have certain tumors which are actually winking at you, which are actually not going to be harmful at all, which are going to be very indolent, and you don't know, you are not able to recognize them. The same way, you might also be looking at the devil in disguise there. You probably will not be able to catch this particular group of patients with very aggressive tumors, which if not treated adequately, might end up in death because of the malignancy. So it is very important for us to identify which patient does which. And in addition, there is a lot of variation. Like there are a lot of available options for treatment of prostate cancer. It can range from active surveillance to active treatment. And out of this, active surveillance is the one which is of major concern. We have to be able to identify patients in whom you don't really have to do anything at all. These diseases, these patients have diseases that are so indolent that they are unlikely to die because of the prostate malignancy in the first place. So for these reasons, it is very important for us to risk stratify a particular patient. So next, how do we risk stratify? Whenever we identify prognostic variable, identifying the important prognostic variable is fairly easy in the manner of like understanding if it can independently predict the prognosis. Like for example, all the three markers, all the three parameters that are shown on the screen here, they are independently predictive of the prostate cancer outcome. Like if it's a PSA, the one on the left is PSA and the middle is lesion scoring and the third is staging. All these three are independently predictive of how a prostate cancer is going to do. And these are the three cardinal elements based on which risk scoring is done, which risk stratification is done. So how do we risk stratify? Basically, prostate is a very common cancer. As a result of that, what happens? There are a lot of researchers working on prostate cancer. As a result of a lot of researchers working on a lot of prostate cancer, what happens? The next result is there is a lot of opinions. If there are a lot of opinions, what is the next problem? The next problem is a lot of confusion, a lot of argument. Confusion for the clinician, for the end user, and a lot of arguments between the researchers. And this is the real state of prostate cancer. Actually, there is a lot of confusion and argument and scope for improvement in prostate cancer. And there is a lot of variation in practice also. But generally speaking, what are the main parameters used for risk stratification? The grade of the tumor, the PSA value, the stage of the disease, like I told before. Life expectancy becomes very important because many of these prostate cancers can be indolent. Even the high risk prostate cancers can be indolent. And then fifth, another very, very important point available is the treatment option profile that is available with you. The toxicity of the treatment, the availability of the treatment, the cost of the treatment, the patient preference, all these factors also have to be taken into consideration into how to manage it. So the fifth point is basically a determinant of treatment rather than a determinant of how to risk stratify. The first 4 points are determinants of how we risk stratify a particular patient. So coming to the parameters that are used for risk stratification, the first 3 are the most important of the lot. That is PSA, Gleason grade, and the stage. So I'm not going through the details of these for want of time. But if we know these 3, on the basis of these 3, they are classified into low, intermediate, and high. Low is basically tumors that have a particular set of parameters, and then high is like low should have all of those parameters, high should have any of those parameters, intermediate is something in between. Other than that, there are other factors also which have a contribution, which potentially make a contribution to risk stratification, and different models are there available, and different ways this risk stratification is done between the researchers, between the countries, between the organizations. There is a lot of variation. So coming to risk stratification methods, whatever I showed before in my previous screen, this already shows how the Europeans approach at risk stratification. This is how ESMO approaches. This is a derivative of a particular classification system called as DMECO classification. And the first 3 parameters, which are highlighted in bold, they determine the risk stratification in ESMO. According to ESMO, there are only 3 grades. But the NCCN actually has subdivided further these 3 grades into 2 subgrades. So the low is divided into very low and low. The intermediate is divided into favorable intermediate and unfavorable intermediate. And the high is divided into high and very high. And this resolution, this particular classification offers a degree of resolution between this one subgroups. Same way, there are several other classifications which are available, which are used by different clinicians based on their preferences, individual preferences, based on their center practices. There is a lot of variation. DMECO is the classification which was adopted by the ESMO. There is also something called as a CAPRA score. And there is something called as a recently developed Cambridge Prognostic Group, where actually it is something similar to the NCCN, but there are subtle differences. Like, for example, this is only a 5-tier system, whereas NCCN is a 6-tier. Like if we considered intermediate as unfavorable and favorable intermediate, and they all seem to be claiming that they are good enough or they are not good enough for. There are so many researches that are like so many publications that have been done on the the applicability, the validity of these models. So what I'm trying to emphasize here is the variation between centers and practices. And then nomograms. There are an endless number of nomograms that are being developed and utilized in prostate cancer. Actually, it goes from center to center. A nomogram is basically a very complex mathematical manner of integrating multiple potentially important prognostic variables into a segregated group in order to determine a particular outcome. Like, for example, the nomogram that is shown here is a nomogram that was designed to predict the upscoring of Gleason's grade following prostatectomy. Like the pre-prostatectomy, like the biopsy Gleason grade and the risk of upstaging of the Gleason grade on prostatectomy. So this particular nomogram was designed for that. So there are many things with respect to nomogram, how applicable. The biggest issue with nomograms is how applicable they can be, because this is sort of like the example that I can give is 3D conformal radiotherapy versus intensity modulated radiotherapy. So what happens in intensity modulated radiotherapy is your radiation doses, the isodoses are so conformal that the particular radiation isodose can be actually, the plan can be more prone to errors. The same thing goes on with nomograms also, because you are trying to conform by using multiple factors and in a very tight manner. You are trying to predict with a higher degree of accuracy. The scope for error can be more. Like the nomogram that has been developed for a particular group of patients, say a nomogram that has been developed in Europe may not be applicable to a nomogram. I mean, may not be applicable to patients that are being treated in, say, India or in United States. So this is a problem with nomogram, but nevertheless, there are a lot of nomograms available for use in prostate cancer. Despite this, we have an inadequacy. There is a scope for improvement. There is always, like, you have classified into low risk, you have classified into intermediate, you have classified into high risk, but there is always some hidden rotten apple there. Like, for example, the curve that you are seeing here is a Netherlands report on patients who were taken up for active surveillance rather than for any active treatment. They were only on active surveillance. So over the course of the years, like over a period of around 4 or 5 years, you can see that up to almost 35% of patients had progression. At least some of these 35% of patients have actually expired because we made the mistake of keeping them under active surveillance. Could we have identified them better? This is a question that needs to be answered, and different methods have been devised to increase the resolution of our ability to segregate patients into low risk, intermediate risk, or high risk, or whether the patient is eligible for active surveillance or not. And in this regard, molecular prognostic test in prostate cancer has increasingly shown its presence in the last several years. The first publication came sometime in 2013, but since after that, there are multiple publications coming, multiple tests that are being developed. And basically, molecular tests look at identifying the genetic make of the particular disease. I mean, whatever the molecular driving factors that are there running, getting the disease running, and then using that information to identify. Broadly, the application can be predictive or it can be prognostic. Prognostic basically to say whether this particular disease is a dangerous disease or whether it is an indolent disease. Predictive in order to say if we can treat it differently. So wherever we have doubt, molecular tests have been utilized to see if there can be any scope for better interpretation, better understanding of the disease treatment. So it can be for choosing of active surveillance. It has been used for predicting of other prognostic variables, like, for example, evidence of lymph node metastasis. It has also been used for tailoring treatment, like, for example, radiation dose escalation has been considered based on the gene signaling, gene profile. Outcome of treatment is basically purely prognostic factor, where actually using the genetic make, they have been trying to understand if the molecular test can predict the outcome of the disease. So point 4 is actually one of the most important application of not most important, most established application of molecular tests. Actually, it is more prognostic than predictive. I'll come to that in a bit. So what are the available molecular tests? There are several molecular tests available, but you can basically classify them into 3: specific genetic abnormalities, gene signature based the molecular tests, and then cell proliferation. These are the 3 segregated groups of molecular tests that are available. Out of them, of importance is the gene signature based, where actually the genetic make of the particular tumor is studied in order to understand how it might be behaving. So with this, we'll go to the molecular tests that are available. Now, like I told before, I'll be concentrating mainly on gene based. And the first test that I'm going to discuss in very brief, in view of out of time, in very brief, I'll be discussing about Decipher. Decipher is a particular genetic test which looks at mRNA expression in the tumor. And it's a complex test, actually, a very complex molecular test. It was first reported in 2013. And in Decipher, what is done is basically the mRNA expression, coding and non-coding mRNA expression out of several. So it was a retrospective study in which post prostatectomy patients who had early metastasis. The specimens of these prostatectomy patients were genetically analyzed or their mRNA expressions. Along with them, some controls in which actually there were some patients post radical prostatectomy who were clinically NED, and then there were some others who had biochemical relapse but no clinical relapse. So three groups of patients were actually genetically analyzed to identify which mRNA expression might be detrimental or which might be protective and so on and so forth. And finally, it was developed on presently, I think, if I'm not mistaken, it is a 22 gene signature, which it basically tests 22 genes in order to predict whether a particular tumor is aggressive or less aggressive. The score is between 0 and 1. 0 is basically indolent, 1 is basically aggressive, and it is a spectrum, a decimal between 0 and 1. Higher the number, more the aggressiveness of the particular disease. So it was developed mainly on prostatectomy specimens, which is basically like large volume tissue, but it has also been adapted. It has also been developed into biopsy based. So there are two types of decipher. One is decipher prostatectomy, and then there is a decipher biopsy. So these are two separate types of tests that are available from decipher. And I won't go into great details here, but decipher on retrospective analysis, this is the first publication that came out, published in PLOS 1 in 2013, and it was able to basically segregate the patients who did good well enough from the patients who did bad. Like, for example, the genomic classifier, the GC stands for genomic classifier. Genomic classifier value of more than 0.5 distinctly did worse compared to genomic classifier of less than 0.5. So this was decipher. Now this proves that it is prognostic. It potentially is prognostic, but is it predictive? With respect to prediction, again, the data is quite poor. Like, for example, if this is a particular study, retrospective study again on active surveillance. So decipher was attempted to see if active surveillance can be it can be able to predict active surveillance, patients who are eligible for active surveillance from patients who are potentially not. And you can see that with reasonable degree, it could identify patients who are likely to do worse with active surveillance compared to this. But it's it does not answer. It is still not predictive in the sense it does not answer whether if I treated this particular patient, will his outcome be different? It does not answer, which is why it is not predictive. It is again only prognostic, even though it is used to predict. It is only prognostic at this point of time. And another nomogram here, this is a nomogram developed in which decipher was also used. The purpose of this nomogram was to identify if there is a role for decipher in segregating a patient who requires immediate adjuvant RT versus salvage adjuvant RT. So following prostatectomy, this nomogram hopes to identify patients who might be benefiting from immediate adjuvant RT rather than wait. And in this regard also, on the retrospective study, it seems to suggest that the test can identify a patient who might benefit from immediate RT away from a patient who might not. So, but all these are basically retrospective studies, not multicentric studies, limited to this one. So all in all, there is no enough data for them to say that this can be strongly considered. As a result, there is a different standpoint of various guidelines with respect to molecular tests, including decipher. Another good thing about decipher is it is developing this particular thing called as GRID. GRID is basically, it's an acronym for Genome Resource Intelligent Discovery. Genome Resource for Intelligent Discovery. Basically, all the genetic abnormalities are stored of all the patients who undergo the test are stored for segregation and then eventual analysis. So there is an artificial intelligence program running, and there is a large volume data repository which is constantly evolving and developing, and which potentially has a lot of scope in new drug discovery and in research, in precision medicine research for urothelial malignancies. So I'll come to the other example now. The next example is Oncotype Dx. Now, Oncotype Dx is an mRNA-based test, and again, the purpose is same. Sorry, it's not an mRNA-based test. It's a RT-PCR-based test. and it looks at 17 gene signatures from different, basically from 4 domains. And again, it was developed on a retrospective data set where Oncotype Dx was found to do better than your traditional risk stratification system in identifying low risk and an intermediate risk from high risk. So, an aggressive patient from a less aggressive patient. But just to post a controversial paper, here is another paper where actually the report suggests that it was not a very good test. Oncotype Dx was not, I mean, it's not nothing against Oncotype Dx or something, but what I'm trying to highlight here is that it is not fully ready for clinical use, at least at our end. It is not fully ready for clinical use, even though there are guidelines that recommend consider genomic testing. So there is one more ProRalis, which is basically looks at the proliferative capability, and again retrospective data seems to suggest that there is some promise in ProRalis in its ability to segregate patients between low, intermediate, and high risk. So why? I come to the next part. Why are they not popular enough? Molecular tests. One problem is quality of evidence. They're mostly based on retrospective data. The second problem is limited data on predictive capabilities. Can you modify your treatment? Can you change your decision based on the particular result? No, as of now, it is quite difficult. You can do it, but it's not, you don't have strong evidence in favor of whether you can really do that or not. Availability is a problem. Cost is a significant problem. I have never asked for requisition, but I think they come to around thousands of dollars, typically around 5,000, 6,000, 7,000 US dollars is the cost of these tests, which is pretty prohibitively expensive for most of us. Applicability is another issue. Like I discussed with nomograms, applicability, if you try to conform your data too much, you are in risk of having errors. But the thing with molecular tests is they're looking at the molecular make. They're looking at the core nature of the particular tumor, which is why applicability probably might not be a problem. So these are the reasons why molecular tests are not very popular as of now. How to decide what to choose? So there are basically two dilemmas for a clinician. One is, how do I risk stratify a particular patient? The second problem is, how do I treat a particular patient? There is a set of options available for treatment, and there is a set of options, confusion with respect to how you risk stratify a particular patient. I will not go into how to treat. I'll go into how to risk stratify. In terms of risk stratification, these are all the factors that are being considered. We have already discussed these in our presentation before. And what do experts say? I can only summarize by telling that there is a lot of variation between the different guidelines. I'm looking at two guidelines here. One is the NCCN and the second is the ESMO. These are the two most probably popular guidelines, at least among us practitioners here in India. And with respect to NCCN, I want to highlight here that it is essentially prognostic. Can you see if you can see the column here, I don't know whether my cursor is visible or not, but in the table 1, no, it's essentially prognostic. It's not predictive. So to understand the prognosis, you can consider utilizing any of these particular molecular tests. And with respect to treatment, like I told before, NCCN has managed to classify into 6 subgroups total: very low, low, favorable intermediate, unfavorable intermediate, high, and very high. And based on that, what I want to highlight here is active surveillance is a valid option, especially for very low, low, and favorable intermediate, with decreasing emphasis. So with very low, there is a high degree of emphasis on considering active surveillance. With increasing risk, there is a lesser degree of emphasis on active surveillance. I'm not going through the greater details of all these things for lack of time. And then the ESMO 2020 guideline conveniently talks very little about molecular tests. It's just a passing remark. That's all. The entire 2020 ESMO guideline has molecular tests as a passing remark only and nothing more. It is not prepared to accept molecular tests right now of the clinical trial. And with respect to classification, risk stratification, it classifies into low, intermediate, and high. and it has clear recommendations on what to do. The thing about ESMO is it is never trying to tight fit the recommendation. That is the thing about it. I mean, personally, I find it quite elegant, where low risk, intermediate risk. I mean, it can be confusing, but at the same time, the thing is you cannot try to make it watertight. That is what the ESMO is basically looking at. So for low risk, you have multiple options. You have watchful waiting. Watchful waiting is different from active surveillance. You have active surveillance. You have RT. You can go for radical prostatectomy. But for intermediate risk, you have to more strongly consider adjuvant, radical prostatectomy or RT with or without androgen deprivation therapy. So in summary, prostate cancer is a very common disease, a very heterogeneous disease, which basically means there is a lot of variation in practice. Risk stratification is important for us to identify an indolent from a lethal malignancy. Risk stratification predominantly relies on these three parameters: GPS, if you want, grade, prostate specific antigen, and stage. There is a lot of variation among clinicians and researchers on how they stratify patients. So how we practice can vary between centers. Molecular testing shows significant promise in better estimation of disease and disease aggressiveness, but different guidelines seem to have different stands, and they are essentially prognostic as of now. Presently, we can't use these molecular tests to predict how to treat a particular patient with prostatic malignancy. Thank you for your patience. I'm sorry I exceeded time by a few minutes.
If you have any questions, we can take them or in the end, and questions. The aspects.
Sir, I'm sorry, I can't hear you. I cannot hear you at all.
Okay, what I said, GPS system that you have talked about the earlier part is a good system to continue for the individual practice. And I only request our AROI Karnataka chapter, and wherever it's possible, the various centers are doing a genomic test today on prostate cancer and various cancer. Today we are concerned with the prostate cancer, and they can even and publish that, and anybody who is interested to avail the services, they can do that, because tomorrow that's where and we are going to make use of it in the future. So that's the most important, collectively use that, and we can have a good report on it.
I think so, sir. I think so. It's a very good, I mean, it is the way forward potentially, but the problem is expense. Right now, it's considering that they're all from abroad, they're prohibitively expensive for.
Not all patients may not be affording, I agree, but the moment the number increases, the expense also decreases. And you give the option to the patient, unless you tell them, and they will not be able to come forward. So therefore, and also wherever it is available, you must give the entire options to them to get it done from those centers.
Correct. And one more thing, just to highlight here, there are other simpler tests available which I have not spoken about at all. Like, for example, P10 loss with IHC, and then Ka67 also has been considered, which are probably easier, but we don't have enough data on them to routinely use in the clinic.
In terms of like genomic testing, actually, there are a lot of companies they offer. Actually, they give the coupons also if they want to use it. I'll ask them to contact you. So, and in the even in HCG, I am sure that a lot of places we are already doing genomic testing for the prostate cancer. But there are like at least I know 3-4 companies, especially for prostate cancer, they are doing some of the they give the coupons, which is worked out for 1,500 or something. So they do around 5 tests in the prostate. Yeah. So we can definitely utilize that.
Okay. Are you talking about one of these tests that I spoke, or are you talking about next generation sequencing or something like that, like metastatic prostate cancer, or?
All the 5 tests, including the like BRCA and next, they're not
that
doing
is, yeah.
for that is what you told that for that they usually do it.
That is basically germline testing for this one. Okay, sir. Okay, mainly for metastatic.
Thank you, Dr. Sharan.
Yeah, thank you.
If they have any questions, they can type it in the message bar and send it over, and we'll be able to discuss. Now we will go to the second talk. Second talk is by Dr. Radhesham, Senior Consultant, Medical Oncologist at CG Hospital. So his topic is updates in hormone and chemotherapy.
Hello. Hello, can you hear me? I'm Dr. Radhesham here.
Yes, sir.
Yeah. Can I share my slides? Yeah. Can you see the slides? Hello?
Yes, sir.
Yes, sir.
Can you hear me also?
Yes, sir. Yes, sir.
Okay. Yeah. I have to thank AROI and Dr. Sridhar for this opportunity. I am going to talk about mostly the castration-resistant prostate cancer, because that can give us a lot of biological issues in that group. So if you look at prostate cancer, we should always look at a balance of 2 different factors. One is the patient factors and then the prostate cancer factors, the cancer itself, which is the usual stage, differentiation, PSA levels, and of course now newer things which are coming up that like androgen receptor mutations, BRCA and all that. And then of course we have got patient factors because there are competing causes of mortality like cardiac, old age, poor performance status and all that. So when you balance these 2 only, you will be able to achieve good quality of life and survival. So I'm going to talk about the advances which have taken place in the prostate cancer. And one of the very important advances which have taken place is the fact that castration-resistant prostate cancer doesn't mean that androgen-independent cancer, because we know that the androgen receptors are still active and newer hormone therapies work well in this situation. So they may be castration resistant or refractory, but it can not hormone resistant or refractory. And what is the basis of this castration resistance also has been worked out to a large degree. And we have got that here testis androgen production and from the adrenal glands. And there are drugs which block the production from the testis, that like LHRH antagonists and agonists, and from the other places, including adrenal glands and prostate cancer itself, producing androgens, and that can be blocked by the newer drugs which we have. And there is a concept which is called hypersensitivity to low levels of androgens, which one of the prostate glands' ability to survive in the environment of low androgen levels. I think this is because of activation of certain genes, which makes a smallest amount of androgens also enough to keep them alive and metastasize. And we know all this regulation. I don't want to bore you with this. But the important thing here was to look at variety of drugs which we have. For example, in the LHRH area, we have got LHRH agonists, LHRH antagonists, and even estrogens in some of the situations which were used widely earlier, but now given up because of cardiotoxicity. And we have got drugs, abiraterone, which is blocking the testosterone production. And drugs like flutamide, bicalutamide, nilutamide, abiraterone, and all that, which variety of levels. So abiraterone acts at several points in the, and then adrenal, again, abiraterone can work. And then enzalutamide is another newer drug which has not been represented here. So we have got a variety of hormone therapies to choose from, but either they work on the androgen receptors on one side or androgen production on the other. And there are trials now to combine these two group of drugs along with the LHRH antagonists or agonists and see whether the deeper hormone therapy success can be achieved. And another very important conceptual change which took place in prostate cancer is the fact that chemotherapy was effective in these cases. And at that time, it was a very, very surprising thing because most of the people assume that prostate cancer is chemo-refractory. The question was the right drug was not used in the right dose because everyone was afraid of the age and comorbidity in these elderly patients. And when you use the right dose, docetaxel 3 weekly, they've started getting the responses and even prolongation of survival. Then the third conceptual change which happened was we were always taught that chemotherapy and hormone therapy can never be combined. And a trial showed that when you combine chemotherapy and hormone therapy, you not only increase the progression-free survival, but you have a large jump in overall survival. And that was another thing which happened. And this is a study which showed that enzalutamide, which is an androgen receptor blocker, compared to placebo. And this also exemplifies one more change which happened in prostate cancer. It was very difficult to look at the endpoints for prostate cancer efficacy, efficacy of the drugs against prostate cancer. And so radiographic PFS, where the changes in the bone scan were counted, and it was used to look at the efficacy of therapy. I think this was introduced for the first time in the prostate cancer trials. This is about the second chemotherapy which came into the prostate cancer, cabazitaxel, and it was proven to be better than mitoxantrone, and later proved that it can be effective after the docetaxel therapy. And it has been, of course, retrospectively analyzed after combining a variety of clinical trials that if a patient can tolerate, if performance status is good, then using the chemotherapy sequentially and then hormone therapy sequentially in a metastatic prostate cancer gives the longest survival in total. So if it is possible, we should incorporate chemotherapy in the total duration, total treatment of the prostate cancer. Though, of course, a phase 3 randomized study has not been done to prove that. This again showing that one of the hormone therapies, abiraterone, can double the time to radiation changes. Radiology changes, their bone scan changes. Now the next question comes is when we use any of these drugs, LHRH agonists or antagonists or orchidectomy, it is very important to see that serum testosterone levels are at the lower level, so less than 50 nanograms, and even preferably less than 20 nanograms per deciliter, because when it is higher than that, the newer hormone therapies don't work. So it is very important before we decide that patient has castration-resistant prostate cancer to look at the testosterone levels. And another conceptual change which has happened is we are classifying the resistance mechanisms into androgen dependent, which is again low levels of androgen from extra testicular origin and all that, to androgen independent prostate cancer resistance, which is increasing the androgen receptor concentration and increase the efficacy of sensitivity of androgen receptors to low androgens, and then even androgen or hormone therapy complete bypass through loss of P10, BCL2, increase of the BCL2 function, overexpression of BCL2, and neuroendocrine like cancer developing in the prostate cancer. So it is becoming very important to do some biopsy or circulating tumor cell analysis to see where the resistance mechanisms are happening. Increasingly, I think that will come into clinic. And a very important question always comes to the clinicians, and which is a big dilemma even today, is should we use hormone therapy or chemotherapy, because these are the two major classes of drugs effective in prostate cancer. And we used to go by the clinical method that a patient, one is negative factors, patient is old, patient has poor performance status, cardiac issues, then don't use chemotherapy because patient may not tolerate, so you use hormone therapy. But that itself is not enough, because if patient can tolerate, then is there a method by which we can know whether there is hormone resistance? So now we have that mechanism. I mean, not completely available in the clinic, but what we call as androgen receptor V7 splice variant. This is one of the common splice variant found in the prostate cancer. And when this splice variant is expressed, then that androgen receptor, prostate cancer will not respond to any hormone therapy, and probably we have to give chemotherapy or the newer therapies like PARP inhibitors. So this is the ARV. ARV7 is defective, and the androgen receptor cannot bind with the hormone, and it is constitutively activated, and even if there is no androgens available, the receptor will be triggering because it is a defective receptor. So that is the mechanism of the hormone resistance in ARV7 splice variant. And this is to say that de novo prostate cancer, if you look at the androgen receptor V7, you find it only in 1% of the patient, or 1% of the cancer cells. Whereas after you give the androgen deprivation therapy and even second line hormone therapy, you will get ARV7 in 75% of the patients. And this can be found in the primary also, as well as in the secondaries. And if you have used the second line hormone therapy, like enzalutamide, for example, or abiraterone, you will find ARV7 in more than 90% of the patients. So if we do this and find in patient specimens, probably it will help us to decide whether hormone therapy or chemotherapy can be more effective in these patients. And this is to say that it has a heterogeneous distribution. It increases in the lymph nodes, but it may be little less in the bone and visceral mets. And in a retrospective analysis, they looked into the patients who have within 1 year of, as I said, abiraterone and enzalutamide had progressed. And most of these cases which progressed had ARV7 mutations. And they looked into a radical prostatectomy specimens. And when the median ARV7 was above particular level, the recurrence, both PSA recurrence and anatomical progression after radical prostatectomy was increased, whereas if it is less than a median level, and then there was increased progression-free survival. So maybe even a useful biomarker even in early prostate cancer. But unfortunately, there is no FDA-approved treatment, hormonal kind of a treatment for this. But people have tried some drugs like niclosamide and all that with hormone therapy to see whether they can reverse this resistance. Okay. So what is the importance of ARV7? It shows increased biological aggressiveness of prostate cancer. It shows reduced efficacy of hormonal therapy. And it shows usual efficacy of chemotherapy and increased efficacy of immunotherapy. That is question mark, but some basic studies have shown that whenever ARV7 is expressed, probably the immune environment of the tumor is better, and there is an increased mortality in this. So it can be both prognostic and predictive marker. Now we come to the third treatment which has become available in prostate cancer, there is PARP inhibitors. We know that BRCA mutation is found in about 5 to 7% of the prostate cancers. And this BRCA mutation is very surprisingly mostly somatic in prostate cancer. That means it is found in cancer cells, but not found in the normal cells. And there is also another group of DNA repair gene mutations called HRR genes, HRD. So homologous recombination defect. And when these two are there, either BRCA mutation, BRCA1, BRCA2 mutation, or HRD, then PARP inhibitors can be useful. And we know that these PARP inhibitors right now are being used in resistant cases after hormone therapy and chemotherapy options are exhausted. But there are now trials which do BRCA mutation studies beforehand and see whether it can be combined with hormone therapy. The advantage of PARP inhibitors in prostate cancer is, since only somatic mutations are found mostly, we can combine these PARP inhibitors with hormotherapy, it can be combined with chemotherapy. Probably it also can be combined with immunotherapy. And whenever BRCA mutations and HRD is present in prostate cancer, a lot of neoantigens are expressed. And usually if you look at prostate cancer, I will go to the next slide. Okay. If you look at the prostate cancer microenvironment, it is an immunosuppressive environment. There are a lot of T regulatory cells. Immunosuppressive cells are more. And T cytotoxic cells are less in number. There is increased production of the tumor necrosis, TNF, and all that. And so generally it is an immunosuppressive environment. But it has been seen that when BRCA mutation is there in the patients, then the environment is better and it is more immunomodulatory environment. And probably immunotherapy can be used in these patients. So one of the hottest area of research in prostate cancer is combination of PARP inhibitors and immunotherapy because there is some evidence that it is synergistic. So it can be used. So these are the, so summing up, there are 4 different therapies now available for prostate cancer. At least 3 are already FDA approved. One is chemotherapy, there is hormone therapy, and there is PARP inhibitors. And the 4th one, which probably will come in quickly, will be the immunotherapy. Each one of these have their own advantages and disadvantages. For example, chemotherapy, though it is in the short run very toxic treatment, but finite time, only 6 cycles of chemotherapy can give you prolongation of survival equivalent to a costly hormone therapy. But elderly patients and patients with poor performance status may not tolerate it. And it has an advantage of being cheaper than any other therapy right now. If you look at the hormone therapy, it has an advantage that immediate toxicities are less, but prolonged treatment, and it can work only when androgen receptors are activated and that axis is normal, and they fail in the when there is androgen receptor mutations, and they are expensive. And then we come to the PARP inhibitors. They work only in about maybe 10 to 15% of the prostate cancer patients, those who have those markers of BRCA mutation and HRD. And again, it can be expensive, as well as it can, in some small number of patients, it can produce second malignancy and all that when used for more than few years. And then we have got immunotherapy, which probably becomes more effective when there is hormone therapy resistance, and especially I think it is useful in combination with hormone therapy or PARP inhibitors. I think right now the dilemma is how to use these in sequence or in combination, and what is the role of hormone therapy when there is BRCA mutation, for example. Should we start with PARP inhibitor? So these are the questions which are being asked, and a lot of trials are going on these areas. Thank you very much.
Thank you for this talk. We will take the questions there. Next, come to the next topic, which is how to select the appropriate radiation dose vaccination based on evidence. The talk will be delivered by Dr. Karthik Rishi, consultant radiation oncologist, Sri Shankara Cancer Hospital in Research.
Good evening, everybody. It's nice to be back in an AROI CME. Thank AROI for giving me this opportunity to talk on fractionation in prostate cancer. So before we go into fractionation, let's first look at what is conventional fractionation. In prostate cancer, it's people joining online, can you hear me? All participants.
You're audible. You're audible, Karthik.
Thank you.
Online, you're clearly audible.
So let's begin by looking at what is conventional fractionation in prostate cancer. Here, the conventional would be around 70 grade 35 fractions, 1 fraction per day, 5 days in a week for 7 weeks. Next slide, please. So
Excuse me. Sorry for interrupting. Your screen is not visible. Your this one is blank online.
They can't see this one.
Maybe you can log off and log in again. I mean, from the screen. Stop sharing and then reshare. Okay.
Is it seen now, Sharat?
Now it is visible. Now it is visible, Karthik.
So the conventional fractionation is 70 grade 35 fractions. So people quickly realized that in prostate you needed higher doses to achieve cure. So generally these 5 trials are quoted for as dose escalation studies. The dose given was around 78 gray, 79.2, 78. Next slide, please. 78, 74, and 79.2. So these 5 randomized controlled trials showed that there is an improvement in biochemical recurrence and local control, but there was no improvement in overall survival, and there was a higher risk of toxicity. If you look at the grade 3 toxicity, it is anywhere between 7% to 10%. Next slide, please. So with IMRT, this could be reduced. IMRT and now with IGRT, dose escalation became a lot more easier. And the toxicity is reduced to 1 to 3% in long-term grade 3 toxicity, that is for GI and GU. So today, if we want to dose escalate, we are doing IMRT and IGRT. So what is the dose escalation if you're giving conventional fractionation for CA prostate? Today we are giving 74 to 76 grade in 37 to 38 fractions, 1 fraction per day, 5 days in a week for 7 weeks. Next slide, please. But before we proceed with fractionation, what we need to look at is what endpoints are we looking at when we are talking about CA prostate. It's not like other malignancies where overall survival is the endpoint. Here, prostate cancer has a long natural history. There's a long follow-up needed to demonstrate overall survival. And the immediate clinical endpoints for cancer prostate group, they showed that metastasis-free survival is a good surrogate endpoint rather than overall survival. So this was looked at in a meta-analysis by Garzai. Next slide, please. And they concluded that metastasis-free survival is a best surrogate endpoint in CA prostate. Biochemical control and local control are not good surrogates for overall survival. So this is an important point when we are evaluating studies. to see whether a particular fractionation is important or a particular schedule is better than the other. Metastasis-free survival is not a surrogate for studies with nodal irradiation and hypofractionation, whereas in these situations, overall survival is a better endpoint. So whatever we are doing, we need to see what endpoint we are looking at in prostate cancer. Next slide. Just briefly to go back to radiobiology, there are high alpha by beta ratio of 10 gray, which is for tumors, early responding normal tissues, but these are insensitive to dose per fraction. Whereas the low alpha by beta ratio of 3 gray, this corresponds to the late responding normal tissue, which is sensitive to dose per fraction. We know this, and this forms the basis of the next talk. The hypothesis is that the alpha by beta of prostate cancer is lower than that of the majority of human tumors. It is close to a value that is characteristic of late responding tissue. Many studies have shown that the alpha by beta is 1 to 2 for prostate. Why is this important? Because if the alpha by beta for dose limiting normal tissue is less than that of tumor, then when you give large fraction sizes, it preferentially kills the tumor compared to the normal tissue. Next slide. So this forms the rationale for hypofractionation in CA prostate, where if you give fewer and larger fractions, it improves the therapeutic ratio with isoeffective tumor doses. It has the advantage of shorter overall treatment time, and it is more cost effective. So when we talk about hypofractionation in CA prostate, there are two main types. One is called moderate hypofractionation, where the dose per fraction is 2.4 to 3.4 gray, and ultra or extreme hypofractionation or Sbrt, where the dose per fraction is more than or equal to 5 gray. So this is how pictorically we look at moderate hypofractionation and extreme hypofractionation. In conventional, the treatment duration is 8 to 9 weeks. With moderate hypofractionation, it comes down to about 4 to 6 weeks. And with extreme hypofractionation, if given continuously, it gets completed in a week, or if it is done alternatively, about 2 weeks. Next slide, please. So there are a lot of trials now which have looked at moderate hypofractionation. RTOG 0415 was one of the earliest. Some of the more well-quoted trials are the PROPHET trials and the CHIP trials. So PROPHET trial and the CHIP trial, here conventional fractionation was compared with 60 gray in 20 fractions, that is 3 gray per fraction. Other studies have looked at 2.7 gray per fraction, 2.6 gray per fraction, etc. But what is more important is collectively these trials have shown that moderate hypofraction is non-inferior to conventional fractionation. There is now quite a bit of follow-up for these trials also, although we can't say that the follow-up is very long, but at least most of the trials have a 5-year follow-up. And with that, we have now come to see that the moderate hypofractionation is non-inferior to conventional fractionation. But there are some caveats which we need to remember in these trials. Majority of these trials dealt with intermediate risk prostate cancer. Only about 15% had high-risk prostate cancer. As I said, long-term follow-up is absent, and especially in prostate cancer, we need a very good long-term follow-up. And most of these trials, pelvic nodes were not included. So when we are interpreting these trials, these points should be kept in mind. So based on this, ASTRO, ASCO, and AUA provided the evidence-based guideline for hypofractionated radiation therapy. They said that hypofractionation is equivalent to conventional fractionation. There are similar late toxicities, but slightly higher GI toxicities. It is superior to conventional fractionation in patient convenience and resource utilization because the treatment gets over earlier. Hypofractionation has been tried in all risk groups, all age groups, any comorbidity, any anatomy of the prostate, and any baseline urinary function. The similar risk of acute GI toxicity, but there is a greater risk of acute GI and similar late GU and GI toxicity. So what is the conclusion is that you can offer hypofractionation today for all patients who have chosen EBRT. What is the dose recommended in these studies? Mainly it is 60 gray in 20 fractions based on the PROPHET and the CHIP trial. Here, this dose has been evaluated for all risk groups, and it has also been evaluated with and without androgen deprivation therapy. So this is a good dose to follow when you're following moderate hypofractionation. Other fractions which are favored are 70 grade 28 or the Fox case of 70.2 and 26. What is not preferred though is the Hippo trial fractionation of 64.6 grade 19 fraction, because here the grade 3 geotoxicity was high. Now we come to Sbrt. Sbrt was first treated in October 2000. If you see over the years, the increase has been from 0.9% to up to 19.5% in 2015. Compared to any other technique, Sbrt in prostate has been people have been very quick to use this. Why is it so attractive? Is because of the short duration of treatment. In only about 5 days, you can finish the treatment, and that's why a lot of people have taken up to Sbrt. But there are certain challenges to Sbrt. Strict adherence to dose volume constraints of OARs is extremely important, because as you know, the rectum and bladder are very closely situated, and their volume constraints should be respected. Advanced imaging modalities are needed for target and OAR delineation, preferably multiparametric MRIs, or some people even use a PET and boost only the gross disease. So some kind of advanced imaging modality is required. Due to the steep dose gradient, reliability is needed for treatment delivery. So you should be absolutely sure of your setups, and your department, your technologist should be well aware of what you are doing. It's very important to reproduce your treatment plan. And IGRT is mandatory. So different methods can be done for this. Fiducial placement is probably the commonest. Western data, they use rectal spacer, intrafraction tracking is done, endorectal immobilization has been tried, and electromagnetic beacon transponders have also been used. Most data on Sbrt is with cyberlymph. The same guideline also looked at Sbrt along with moderate hypofractionation, and they concluded that there is limited data available, mainly single-arm studies, and no RCTs proven efficacy, limited follow-up. And so they said there's a conditional use, and very important is if you are doing Sbrt, not to increase the dose beyond 36.25 in 5 fractions. So their conclusion was routine use of Sbrt is not recommended. After that, there were 2 phase 3 trials which came up. One was the Hippo Rtpc trial. This compared Sbrt with conventional fractionation, and one of the first RCTs to do so. Here they compared 42.7 grade 7 fraction versus the conventional fractionation, and the endpoint was time to biochemical failure. And when they looked at the result, they found that the failure-free survival was the same. There was slightly higher acute toxicity, but the baseline came down to within 3 months, and after that, the late toxicity was the same. So their conclusion was ultra hypofractionation is non-inferior. There is a slight increase in acute toxicity, but there is no difference in late toxicity. The other trial which looked at acute toxicity was the phase 3 trial, which was published about 2 years back. Here, Sbrt was compared with IMRT. So the IMRT arm had 78 grade 39 fractions or 62 at 20, and the Sbrt arm had 36.25 grade 5 fraction. The endpoint again was freedom from biochemical or clinical failure. So once again, if you look at the graphs, there was no difference in acute toxicity between the 2 arms, and the Sbrt arm, the toxicity occurred a little earlier. So these are some encouraging data today to say that Sbrt can be done, but with good IGRT facilities to be used. So today, what are the indications for Sbrt? NCCN says any risk you can use, either low grade, so low risk, intermediate risk, or high risk. But Astro, ASCO, and AU are very clear that if you want to do Sbrt, it should be only for low and intermediate risk and not for high risk. During the COVID pandemic, Sbrt proved to be a very useful modality. A lot of people did 5 to 7 fractions to quickly finish the treatment. Let's not forget about brachytherapy when we're talking about fractionation. I'll show you 2 pictures. Look at the dose distribution with the technique. The first figure is IMRT, second is VMAT, third is Sbrt, and 4 is brachytherapy. The conformity of the dose, especially the low dose, is very good with brachytherapy. But we must remember that brachytherapy was one of the earliest modalities to use hypofractionation. Next one. The second one shows more recent techniques as well. VMAT, proton therapy, carbon ion therapy also do not have the kind of conformality that brachytherapy has. Next. But unfortunately, brachytherapy is not being used a lot because the training has reduced across the world. If you look at this graph, only about 73.7% of the institutions do less than 12 cases a year. That's about a case a month. And only 1.5% do more than 53 cases. So as a result of this, the students are not exposed to brachytherapy, and so they don't consider it as an option when treating prostate cancer. The indications for brachytherapy are monotherapy, very low, low and favorable intermediate, whereas boost after EBRT, unfavorable intermediate, high risk and very high risk. Brachytherapy doses are now well established. If you are doing monotherapy with HDR, with iridium-192, it is 13.5 gray in 2 fractions or 9.5 gray PID into 2. With LDR, iodine-125, it's 145 gray, iridium-103 is 125 gray, and cesium-131 is 150 gray. For boost, HDR boost with iridium, 15 gray into single fraction. Here, single fraction has a role, whereas in monotherapy, single fraction has been shown to be inferior. And 10 to 11 gray into 2 fractions are commonly used. With LDR, 100 to 115 gray, 100 gray or 85 gray with the different radiopharmaceutical. Please. What is the role of changing fractionation in post-prostatectomy situation? Mostly single institutional studies. Feasibility and toxicity studies only published, no long-term follow-up or strong randomized trials available. The dose generally used in this situation is 62.5 grade 25 fractions, 52.5 grade 20 fractions, or the least 42.6 grade 10 fractions. There was one systematic review that looked at hypofractionation in the post-operative situation. They had about 1,208 patients with a median follow-up of 30 months. And their conclusion was that acute toxicity does not seem to be increased, but the results of late toxicity are conflicting. And they just said that there's some encouraging results on local control, overall survival, and biochemical recurrence-free survival. But these results are not encouraging, and I think as of today, we can only stick to conventional fractionation in the post-prostatectomy situation. So what about changing fractionation to pelvic nodes? When a moderate hypofractionation is being used, the high dose per fraction goes to the prostate, whereas the conventional fractionation goes to the lymph node. But the Saturn trial looked at giving hypofractionation to the pelvic nodes as well. They gave 40 grade 5 fractions to prostate, it's a phase 1 trial, and 25 grade 5 fractions to pelvic nodes once a week. And they said that there's no grade 3 or higher toxicity reported. It was feasible and well tolerated. So there are more trials that are awaited. So this is the current situation of different fractionation. We can see that there is a downward trend of brachytherapy, increase in moderate hypofractionation, and a definite increase in Sbrt. So finally, what do I do in prostate? Moderate hypofractionation for all external RT if no nodes. I prefer to use 70.2 gray in 26 fractions. That's the Fox-Chase schedule. Conventional fractionation if nodes have to be treated. Post-prostatectomy, I stick to conventional fractionation, 66 to 70 gray in 33 fractions. Brachy boost, if the patient is agreeing, it's an invasive procedure, so it becomes difficult to convince the patient. But if they do agree, then boost, brachy boost with EBRT, and I don't do Sbrt. Thank you very much.
Dr. Karthik. We'll move to the next talk now. The next talk is going to Dr. Nagaraj, consultant radiation oncologist, Hippo Hospital, Bangalore.
Good evening, all of you. After those three interesting topics, there is a very basic topic, including plan evaluation and implementation with prostate cancer. So before we proceed with the contouring, we have to give certain instructions to the technologists.
Sir, I'm sorry, again, I'm interrupting. Sir, can you just share the screen on for online attendees?
Sir, you're able to see the video, sir.
Right now, we are seeing the video of the screen, but it will be better if.
I think so. For this topic, we also. You need to see the slide as a video, right?
So you need to So before we proceed with the contouring, we have to keep certain things in mind and give instructions to the team. Regarding MRI, some people say it's mandatory, some people say it's optional. But in routine practice, when we are using conventional fractionation MRI, for the planning for fusion, it may not be required because even if we fuse it, it will be done at two different points of time and the fusion won't be accurate. Maybe we can keep the MRI side by side and take the cycle infiltration or the capsular infiltration into consideration. However, for Sbrt, it can be done at the same point of time. And ultrasound guided coordinate insertion into the prostate 1 week prior to the planning CT acquisition. We follow it, but again, when I discuss with my colleagues, some of them they say they don't do it because the cone beam CT they can visualize the prostate as well as the submacular cycles because the quality of the CBCT is pretty good. And we generally prepare the patient. Bowel preparation is done. Dulcolax 5 mg. 2 at a time, the previous using will be given, and the patient is asked to be on NPO. And if no contrast is given, they can take clear fluids just to ensure that the bowel is not full and gas is not formed when we acquire the CT scan the next day for planning. Prior to planning, we generally take a check CT at the mid-level of prostate to see if the rectum is adequately empty. Rectal Epi diameter, we generally try to see if it is less than 3 centimeters because you can see here in this representation, as the rectal girth increases, the prostate gets pushed, and the very first day when we acquire the scan, probably there is an error, and after a few days of treatment, usually the rectum tends to be empty, and we systematically get the errors. That's why we prefer to get this Epi diameter of the rectum less than 3 centimeters. And for all patients, we use the water protocol. Patient voids urine and then takes 500 ml of water, waits for 45 minutes, and after that we do the scan. And the same thing is followed when we do the treatment. Though this water protocol does not impact the prostate position, it will help in minimizing the dose to the bladder or the small bowel loops above it. And we use a simple positioning that is complex, and we use 4-point tattoo. We don't use any cast. And 3 mm slice CT scan, D12 to mid time with contrast if nodes have to be covered, and 4-point tattoo. And Sometimes we get this PSMA PET CT scan, especially if we have to boost the nodes, if at all it is PSMA heavy. And just to brush on the anatomy, the bladder and the periurethral zone and the transitional zone, the anterior fibromuscular stroma, and the peripheral zone and the central zone. Why we need to know this? Because nearly 75% of the prostate cancers they arise from the peripheral zone, and 20% in the transition zone, and very less in central zone. And before we proceed with the contouring guidelines, just to brush on the MRI anatomy, which is considered at 3 levels, that is at the base. This is the peripheral zone, this is the transitional zone, and this is at the mid level. And just before this apex, this is below the apex, and just above that, this is the previous slide was the pelvic diaphragm, and this particular region is the apex of the prostate. And this is the transitional zone. And anteriorly, what we see, this black color is the peripheral zone posteriorly. And anteriorly, this is the fibromuscular stroma, the central zone, which is pyramidal, and the seminal vesicles. And the neurovascular bundle is posterior to the peripheral zone. And when we talk about contouring, because identifying the apex becomes quite difficult, that's why most of the presentations or most of the publications, they brush on this penile bulb, which is formed by the spongiosum, corpora spongiosum, and just above that there is a gap, that is the pelvic diaphragm, and above that the prostate sits. So here this is the bulb, penile bulb, and posteriorly the rectum, and is the dura of the penis and the levator ani muscle. And how to identify the apex, this particular article mentions, and they have shown the MRI and CT side by side, because most often we don't use the MRI, we generally use the CT. And this is the penile bulb. First we identify the penile bulb, and between this penile bulb and the corpora there is a fat space. Then above that there is this loss of fat space, that is the inferior genitourinary diaphragm, and then it is circular in the mid genitourinary diaphragm, and at the superior GUD it is hourglass shape. But sometimes it is difficult to identify on the CT. Maybe if we have the MRI side by side, probably we can correlate. And above this hourglass whatever shape space is the apex of the prostate. This is how we can identify the apex of the prostate. Once we identify the apex of the prostate, then we move upwards, and probably contouring becomes easy. And generally there is a space between the penile bulb and the prostate that's around 1 to 1.2 centimeter, either 3 or 4 slices above the penile bulb. And this article also mentions what mistakes we generally do. And here, this is the correct contouring, where it almost looks like a circular shape, and then this is the 1 centimeter gap between the prostate and the penile bulb. That is the GUD. And sometimes we tend to include this genitourinary diaphragm in the contouring of the prostate, or sometimes we tend to make it a teardrop shape, or include the rectum posteriorly, because sometimes if rectum is quite close to the prostate, sometimes we might tend to contour the prostate towards the rectum. Sometimes we might include some seminal vesicle as the prostate, and so on. There are various mistakes which can happen. This article highlights that. And coming to inclusion of the seminal vesicles, for intermediate risk, 1.4 centimeter of the seminal vesicle or the proximal seminal vesicle has to be included. For high risk, 2.2 centimeter of the seminal vesicle, as mentioned in the Astro Acron consensus guidelines published in 2018. And coming to the extracapsular extension, include the area of suspicion of extracapsular extension. In the absence of ECE on MRI, no additional expansion is required. Whereas the earlier guideline in 2006 had mentioned that we have to give uniform margin as a CTV after contouring the prostate, but we don't do that these days. We just take the MRI information and try to include that extracapsular extension. If on the CT we are not able to identify this extracapsular extension, maybe after contouring the prostate 3 mm in the inferior, lateral, anterior, and posterior direction, we can give the margin with the exclusion of the rectal contour. And PTV margins, it basically depends on each institute and how comfortable they are. Like Dr. Karthik mentioned, what modalities we use, whether we use a simple technique or whether we use image guidance or whether we use fiducial marker and so on. So usually we follow this online correction and we give around 7 mm expansion around the prostate and extensive margin reduction, because some people try to reduce the posterior border to minimize the dose to the rectum. Instead of 7 mm, 5 mm, that is acceptable provided their protocols are stringent and somebody verifies it. At the prostate level, it is not a problem, but if we are including the seminal vesicle, probably the margin reduction may be a problem. So extensive margin reduction might be detrimental and should be avoided. And just to demonstrate this contouring for the prostate, intact prostate. So it is important to delineate the normal structures also correctly, otherwise the dose may vary. So rectum is contoured from the rectosigmoid junction. So that is a normal structure. After that, we first try to identify the penile bulb, because then it will be easy to identify the apex. So above this, you can see here this 1 centimeter distance from the penile bulb above. This is contoured as just a second. This is the penile bulb. Above this, and just for demonstration sake, I am contouring the pelvic diaphragm. That would be probably the hourglass shape, this one. And now here we can visualize the apex of the prostate. And the distance between the penile bulb and the apex of the prostate is nearly a centimeter or 3 slices above. Some of them start contouring the apex of the prostate from here, or they might start contouring from the mid-level of the prostate and come down or up. So I have started contouring from the mid-level of the prostate here, posteriorly the rectum. On the sides, we have to avoid the levator ani muscle, and anteriorly we should not include this space behind the pubic symphysis, because those contains vessels. And higher up, we extend the contour to, once we see the seminal vesicles, we have to include the last prostate, and above the seminal vesicle also starts, we have to include the seminal vesicle as well as the prostate, go upwards. And based on the intermediate or high risk, whether to include 2 centimeters or 1.4 centimeter, depends. And here I have contoured the seminal vesicle, and lower down from this cut, I'm going lower down to include up to the affects. Here I've just trimmed the anterior portion which I had contoured in excess. And fine tuning can be done after seeing the sagittal images. And that is the final volume of the prostate and sematocyte. And coming to the dose constraints, it depends on what protocol we use. Standard 2 grays per fraction, we use 76 grays in 38 fractions, and most of these fractionation is or the dose constraints are mentioned in one of these protocols where they have compared standard fractionation versus hypofractionated, moderate hypofractionated schedule. I'm not going to go through that in detail, but I demonstrate one case. And if we choose around 70 grays and 28 fractions, the same article, Energy Oncology Updated International Consensus, published in 2020, that mentions everything. And the CHIP trial, Dr. Karthik mentioned 60 grays in 20 fraction. The constraints are like this. And the phase 3 trial also mentions its standard dose constraints, which needs to be achieved. And PTV margins in Sbrt prostate, if at all we are using the extreme hypofractionation, then probably we can reduce, but we cannot make it zero. There should be some margin because there is deformation in the prostate, so that's why we have to account for that, even if our verification protocols are stringent. Plan evaluation. So this is the same patient wherein I showed the contour, and we use ADAC Pinnacle, and once the physicists say that they have calculated and this is the dose constraint form what we have initially given to them, and we see as usual slice by slice coverage, and if at all anything missing or anywhere excess, we see in all the planes. I'm skipping all these things, but which you all do repeatedly. And once that slice by slice verification is done, our system, it has both the graphical DVH and tabular DVH, and this is used whichever is convenient to them. And once we see the graphical DVH, and below here the mean max values are there, and we start noting down the values. The coverage in this case it's around 96.79%, and we also note down the 107 and 105. 107 is almost 0 and 105 1.8. And B65 we keep it less than 25% and B40 less than 50%. We can also see B76 and try to see it is less than 2 cc. And almost all those constraints as per this protocol is achieved. And this is what we see in plan evaluation. And coming to treatment implementation, we follow this image-guided radiation treatment, and we have two systems. One is the Elective Infinity, and the other one is Immunotherapy with Synchrony. And on Elective, we have this cone beam CT imaging, and we also use cold seed markers. And cone beam CT, the advantage is can visualize the prostate gland, OAR, pelvic lymph nodal sites. The rotations or deformations of prostate and SV can be visualized, and we use soft tissue match on cone beam CT. And cone beam CT and implanted fiducial also can be used, like I showed in this case where we can got this gold seed implanted. The advantage of this implanted gold seed is basically inter-observer variation can be minimized. If at all doctors are not available in that area, probably the technologists, senior technologists can also visualize. Whereas if they are just doing a soft tissue match, probably sometimes there can be variations in match. And on tomotherapy, that is that X9 with Synchrony, which we have this intrafraction tracking, that is Synchrony, like how they do in CyberNet. It also requires a couple of images while the beam is on, and that if there is any variation, we can interrupt and correct it. correction protocols, earlier we used to do offline, but these days mostly it is online correction. And it has a proven biochemical progression-free survival advantage and reduces the systemic error and random errors also. And interaction motion, as I mentioned, any of these either in cybernet or in the Radixact X9 signal can be used. Usually translational corrections can be done, however, rotational errors are feasible with the 60 OF or 60 degree of freedom couch or robotic delivery systems. Just to show to the postgraduates, this is the Mvcd. So we can match, we can clip the box to the root seed or the prostate when we are treating only that area. And we have to include whenever the lymph nodes are this one. So here the errors are almost 0 to 1 millimeter after applying the correction. The seeds match well. And, that's the advantage of the good seed. The other system, this is the synchrony. Here, once we do the Mvcd verification, we identify whether the seeds are matching. Post that, the system acquires. We can choose whether it is 4 or 6 kV images, and here we have we have done the blending of kV and the DRR images, and the seeds are exactly matching. And once we start, the system starts acquiring whatever number of images we have set, and if there is any deviation that is shown here as a rigid body deviation or the target offset, and we can interrupt if it is because if there's a gas filling and that the target shifts, then we can interrupt, recorrect, and then continue with the treatment. And all these things are recorded for all the 30 days. Though the system is capable of documenting it and we can pull it out, we still do a manual entry. And most of the errors are within whatever 7 millimeter we have set. And even if it is there, that is corrected. And coming to the post-operative contouring, indication for post-operative radiotherapy, earlier PT3A, T3B, margin positive or node positive was included. But these days, the thing is we wait till the PSA goes up to 0.2, but when there is nodal involvement is there, it is better to start early. But still, for the patient to recover from the post-operative side effects, at least 6 to 8 weeks, we have to wait or wait till the PSA rises or almost comes up to 0.2 nanogram per ml. But if we wait too long and the PSA starts jumping more than this, then probably whatever the benefits of radiation treatment also keeps reducing. So in this article, they mentioned this, that an alignment of radiotherapy after radical prostatectomy. It's a randomized controlled trial. And why post-prostatectomy radiotherapy? Because Dr. Karthik was mentioning, finally, what we see is overall survival, because sometimes we cannot be able to assure that at least the biochemical relapse-free survival or something which comes up in the node, all these things we can have an advantage by doing the post-prostatectomy radiotherapy. But this particular article, it clearly says that local regional failure and metastasis is much lesser compared to observation, compared to giving radiation. 22% local regional failure is reduced to 7, and metastasis also is reduced from 16 to 1. There is a significant advantage adding post-prostatectomy radiotherapy. And what is the commonest site of local failure after surgery? It is usually the anastomotic site, 63%, then the bladder neck, 10%, and retrovesical, 17%, and elsewhere 10%. Why we need to know this? Because when we are contouring, we have to keep all these things in mind and adequately cover in these regions. And most of the guidelines incorporate these findings and try to recommend what needs to be covered. And when we see at the anastomotic site, it is mostly posterior 60% and anterior 20% and lateral 15%. And there are various guidelines, RTOG, URTC, PMH, and GETU. And most of these almost mention the guidelines, they are almost similar. There will be some variation in the superior and posterior direction. And most commonly, we use this RTOG guidelines. And anteriorly, they mention posterior edge of the pubic bone and posteriorly anterior rectal wall. And we have to avoid contouring into the mesorectum, inferiorly 8 to 12 millimeter below the vesicourethral anastomosis. That we should be able to visualize. And if we are not able to visualize, probably one slice above the penile bulb, if we, like the intact prostate, I mentioned penile bulb, first we contour, then everything becomes easy. Laterally, the levator ani or internal obturator internus can be included. It has to be, up to that we have to include, not include the muscles. And coming to the nodal target, elective nodal irradiation is controversial. There were 3 trials which did not show any benefit of elective whole pelvic radiotherapy or prostate-only radiotherapy, but the recently published POP-RT trial by Dr. Vedant Murthy, he has mentioned that using the Roche formula, if the risk is more, it definitely adds advantage, including the nodes. There are other trials which are yet to be published. So, elective nodal irradiation in prostate cancer, this particular Lancet 2021, which is a review article, it clearly says that there is an advantage of inclusion of the nodes. But if somebody is hesitant, probably they can use the PET-CT scan. And if PET-CT scan shows clearly some heavy nodes, then probably those patients have to be treated with pelvic nodal contour. And again, the contouring of the pelvic nodes, it varies from protocol to protocol. So RTOG just mentions between L5 to S, whereas pivotal trial, they clearly say lower part of the L5, and Elective trial, again, it is much lower. Whereas this POP-RT trial, it says we have to include up to the bifurcation from the aorta, that is the common iliacs. And this, if we see in this particular article, mapping of pelvic lymph node metastasis in prostate cancer by PET-CT scan as well as the surgical method. If we include from the internal and the external iliac up to this level, as mentioned in the Elective trial, probably it covers most of the lymph nodal sites. But when we do these PET-CT scans, because in India we see most of them advanced, relatively advanced prostate cancer. So they, in the PET-CT scan, we see most often some of these nodes at the bifurcation from the aorta with the common iliacs. So it is good to include, that's what this review article also mentions. And briefly to mention the contouring of the lymph nodes for postgraduates. So we start at the bifurcation from the aorta, the common iliacs, and then laterally up to the psoas, anteriorly 7 millimeter around these vessels. And as we go down, we include the presacral area also, include the internal and external iliac, and then 1 centimeter margin has to be given anterior to the external iliac vessels, and the presacral nodal contouring we have to stop at S3, and we follow the external iliac and pudendal vessels, and give a 1.5 centimeters to 1.8 centimeters width in this particular area between the external iliac and the pudendal vessels. And when we see this medialmost part of the sternum, we have to stop contouring the external iliac and continue it as the obturator till the obturator artery exits, and till then we include the obturator group of lymph nodes. And this is to demonstrate the post-operative contouring guidelines for the prostate. So we start from the mid prostatic region and then go down. And whatever post-operative changes on the anastomotic side we include. And posteriorly, you see here, we have to include this space, but not go too posterior to include the rectum. Anteriorly, it is good to include just means the behind this pubic symphysis pubis, we have to include up to that because it's a operated area, so the anatomic boundaries are not very, this one it is breached. And once we see the penile bulb, just one slice above that, if we are not able to identify the anastomotic site, we can stop that. And then continue upwards. So this particular region is basically to cover the seminal vesicle region, and they say 1 centimeter if seminal vesicle is not involved, we have to include upwards posteriorly, including 1 centimeter of the bladder, and anteriorly and superiorly we continue contouring up to the radial edge of the pubic symphysis. So we take this contour up to the radial edge of the pubic symphysis. After that, we retract it to include only 1 centimeter of the posterior part of the bladder, and better to avoid this mesorectum and laterally up to the lateral pelvic wall. We have to continue, and this distance upwards to include the seminal vesicle bed depends on whether it's positive or negative. 1 centimeter or 3 centimeter, it depends. That's the prostate bed. And nodal, I already discussed, so is the nodal contouring. And uniformly, we give 7 millimeter margin to this as a PDU. Thank you.
Thank you, sir. It was a very informative talk. I think we will go to the next part of the program. I invite Dr. Rupesh to start the panel discussion. Probably we will stick to 1 or 2 cases only and finish it off first.
Good evening, everyone. Is it fine?
Hello. Good evening. I'm Dr. Rupesh. I'm a radiation oncologist. Everything has been clearly covered by our speakers, so I won't take much time. It is just like simple question and answer session because everything has been clearly, nicely covered by our speakers. I have only 2 cases, and I'm touching upon the places where we have confusion. So I invite Dr. Krishna Sharan, Dr. Radheshan Nayak, and Dr. Karthik Rishi, and Dr. Vadiraj for the panel discussion. I think Dr. Radheshan sir is available online for the discussion. So go to the next slide. One one case I had was a 60-year-old man who read a newspaper article about prostate screening. And he's keen to get screened for the prostate cancer and approaches the oncologist for the advice. What advice would you use against prostate screening?
Prostate screening is recommended over the age of 50 years, and usually it is a digital medical examination and the PSA body.
Is it like after 50 years, every patient, every person has to go for prostate screening? Or
Yes.
yeah. So, but there are some trials like PLCO trial which has been done about prostate screening. Because PSA is very inaccurate it can be raised in other benign conditions as well, and over-diagnosis, over-treatment. Prostate cancer screening is done only for like high risk cases and family history positive patients, and anyone who insists that they have to go for prostate cancer, we cannot deny that. So we have to advise prostate cancer screening. Next page. So there are some guidelines for prostate cancer screening established. So this patient was advised prostate cancer screening, but he was inconsistent and did not go ahead with proper screening. After 5 years, the patient comes with complaints of LUTS. DRG showed hard, craggy, nodular, enlarged prostate. How should we investigate? We all have explained that. He undergoes serum PSA, multiparametric MRI, and respiratory biopsy. And one thing we should make important here is bone and soft tissue imaging is recommended from unfavorable intermediate risk onwards. And we always talk about estimated life expectancy, but we should also know how it is calculated. It is calculated through WHO life table or MSKCC life expectancy tool. And as Radheshyam discussed, now genomics, somatic mutation testing is all done in metastatic prostate cancer. NCCN also recommends genomic testing in metastatic, regional, and very high risk prostate cancer. So this patient underwent investigation. Serum PSA was 8. The MRI showed small nodule of low signal intensity in background in the peripheral zone. It was T2A-N0. Biopsy was acinar adenocarcinoma, Gleason score of 3+3, and grade group of 1. This was the MRI showing small prostate, small prostatic enlargement that has been done. There are, as we know, there are many options for this. This patient categorizes to low risk prostate cancer. So we have a number of options: active surveillance, SBRT, radical prostatectomy, moderate hypervaccinated therapy. How would you choose? How would you choose? If Dr. Krishna can I ask him, because he covered that, how would you choose which one to opt for?
I'm sorry, Dr. Rupesh, did you ask me or?
Yes, sir.
Okay. So, yeah, again, I can't see the screen. Okay, yeah, now I can see. So, with respect to whether to treat or not, the first question is whether to treat or not. The next is what treatment. Now, with respect to this patient, at least based on the clinical findings and MRI, they don't seem to match, but we'll take the MRI finding. And if MRI is suggesting a very small disease, a T2A disease, and it's a PSA low, and the Gleason grade also has been reported as 6, I think we can take the patient up for active surveillance, despite, irrespective of what is life expectancies. Another problem in decision making here is PSA velocity, I feel. PSA velocity, there are different ways of estimating. I'm not sure actually about how it can be incorporated into deciding how to go about. There are various ways of doing. I think there is a lot of heterogeneity in how Psa velocity is estimated. But all in all, I am inclined to say active surveillance is an option for this patient based on the available report.
Active surveillance is also a good option. So when we mean active surveillance, we should keep it in mind that it is monitoring the patient with DRE, PSA, and MRI. Whenever a patient progresses, we will have to intervene and treat. So, and active surveillance is allowed till favorable intermediate risk stage. So this patient was advised active surveillance, but we also have brachytherapy as an option. Brachytherapy, there are set criteria to be followed to do brachytherapy. Like it should be, it is an option. Brachytherapy is an option till favorable intermediate risk, and patient should have good urinary flow rates. And it should be a small prostate volume of less than 50 cc.
So regarding the active surveillance, how effective in the clinical practice people will active surveillance? Like Sharon is saying that, is there any case scenarios you have really done the active surveillance or anybody of that nature? Because it will be really difficult. So what is your opinion? Active surveillance is how effectively?
It would be an option for this patient, considering like Sharon mentioned that PSA density and there is a number of pores. So basically, if it's a low volume disease confirmed, so it could be one of the options. I have a very limited experience of 2 patients. So they did reasonably well for fairly long periods of time. At some point of time, they progressed.
What do you actually do?
Yeah, like you tell that okay, it's going to progress one or the other like how
What
to
are
explain.
the methods that you follow during active surveillance?
So-
Frequently.
Oh, so these patients, what I am saying that so this was done initially for first 5 years or so, 6 monthly. So it's a PSA and an examination, and we never did any biopsy again. So this for clearly so that's all. It's mostly PSA based. Both patients are outside Bangalore, and so it was a email based PSA.
So they like they're aware that like there's going to be that is one of the big challenges like it's on the other time.
So I think many people, even in Western countries, once active surveillance is offered, that depending on what time frame we look at, 20 to 30%, they're unable to take this strain of going through that. I may be having something, I'm not taking treatment, and they're typically at that stage. So that what you said is a very valid point. So it needs to be stressed to the patient that you may progress to a higher stage or higher grade or whatever, what you know.
Still, it's probably much simpler compared to seminoma where you observe a lot of imaging and all this.
Yeah, it is.
That's why it is much.
It is definitely, yes.
Thanks to PSA.
Definitely simple.
So Sbrt is also an option. But this patient ended up with urologist and ended up in radical prostatectomy. Histopathology post-op was T2A acina adenocarcinoma, Gleason score of 3+3. Margin at the apex was positive. PSA at 6 weeks post-op was 0.05. Now we have NCCN guidelines telling if there are adverse features like margin positivity, have to consider for post-op RT. But as the sub showed, radical RT LRT trial clearly proves that only salvage RT is enough. No need of immediate post-op RT if PSA form is good. So, what should we consider for a post-op RT in this patient, sir?
For the PSA groups, we have to see we have to monitor and see if it goes nearing 0.2, then
So in this it was just 0.05. So patient was advised only to the follow-up.
So there are also confusion about EBRT plus or minus ADT is there. So like it's the moment it is more than 0.5, a lot of patients comes with ADT. So that is like, no, I feel like it's probably overkill. By the time like
There's only one trial which is looked at it. It's the RTOG 0534 trial. And they were of the opinion that anything more than 0.5. So you give ADT, short course ADT for 4 to 6 months. But when do you start? It's still unclear.
And with robotic, I think there are a lot of positive margins, but the PSA still exists for a long time.
There is some guideline by the American Society of Urology, there's only 8 to 9 points where there's the indication for this thing. And when to start the question, like there's only a node positivity, like a cut margin positive, nothing. Still the urologist is not refer the case to you. So the only thing they're looking at like if it goes fine.
only PSA.
They give 1 or 2 cycles of adrenal rocket, then it is. So second is, as it was mentioned, we will start only after 6 weeks and 8 weeks because of the post radiation stenosis or whatever it is. So when to start the question, but there are some guidelines, but nobody follows. The urologists after surgery, they never refer the case to us.
No, they said that
extreme opinion. There are some urologists, when we say that it is not indicated at this point of time, they want us to. That also is their way of saying.
there are very few urologists like that.
Making the indications are there, and the guidelines also there, but still there is a, especially with these adverse events like lymph node involvement, PNI is there, there's a cut margin positive. So some things are still
It depends on what articles is there in the urology domain.
Yeah, so but like it's RT indication is still fine, but adding on the ADT at that point of time is like it's
One of the reasons which we have, which I have encountered, that many of the urologists are still, as far as radiation is concerned, they are still in the ear gap. So they still talk of, and they also the patient, they talk of proctitis, etc., etc. Doesn't happen, and they genuinely believe in that. So I think at that stage, only it's up to us to interact with them and try to tell them that it's not. So they still have. Many of them use it as a kind of tool to keep the patient away.
Yeah.
But many of them genuinely believe.
They even go to the extent of saying fistula. That's what I have heard in the meetings.
And even for like the stage like 1, then go for inflation. It is a common problem.
They know architecture. Even like in a hospital, a teaching hospital, they do this.
no, and even there are a lot of patients post that they would have done tough and immediately they want us to give reasons because they have messed up.
So this patient was advised only salvage RT in FDT, and then after 6 months, PSA began rising, and it was 2.5. Would we consider this as a recurrence? Basically, this is the notion of biochemical recurrence. There are 3 definitions of biochemical recurrence. The PH definition is nadir plus 2. One more definition is doubling times less than 6 months. So now, patient was, because it was a recurrence, the patient was considered for salvage RT. Some has clearly explained about post-op RT and salvage RT, how to contour and all. So these are all the well demonstrated by Dr. Vabina. So go ahead. So after 6 months of completion of radiation, this patient complained of rectal bleeding. I want to ask how frequent is rectal bleeding as a side effect in IMRD?
What dose you are given? You mentioned that.
66 gray in 33 fractions.
Yeah, very again, rectal bleeding with that dose is not safe.
Mostly radiation technique was not proper and all. That also could lead to so if that occurs, maybe if like in a radical setting, if we do radiation, 74 gray and patient develops rectal bleeding, I think it is not that common in IMRD, but if that occurs, how are we managing?
So I had a patient who was treated elsewhere and who came to me only for management of rectal bleeding. So you first try to do a colonoscopy and you confirm whether the bleeding is because of post-radiation. Most commonly, you will see telangiectasia gas and then radiation changes will be seen. So initially, most important is these patients will have anemia. You need to manage the anemia. And then you can start with giving steroid enemas, and it settles down with that. Only if we see ulceration and necrosis, we'll probably look at hyperbaric oxygen or look at Prognostic. But I have not encountered those. Whatever bleeding was there subsides with steroid enema. And he did very well for a long time after that. So our endoscopists can offer a APC coagulation procedure, which is fairly effective. And when the bleeding is mild, is intermittent, I think stools of laxatives also can play a part. They also can help. So it's very important these people that the stool is not hard, but they find it difficult to control.
Maybe self-limiting after the ones, after some time.
It can. In many people, just with laxatives, that's why it is grade 1, so it can reverse it.
Reassurance.
Yeah.
So coming to phase 2, this is also again a 60-year-old man, complaints of frequency of intubation. Serum PSA was 50 and MRI showed PPB0 tumor. Adenocarcinoma, a Gleason score of 4+4. Iris. Vaccination also was done, which showed locally advanced prostate cancer, and vaccination is shown here. Again, we have many options like neoadjuvant hormone therapy, neoadjuvant hormone therapy, EBRD, vacuum boost, and hormone, and neoadjuvant hormone followed by surgery. So, which option do you choose, sir? Okay. So this I was supposed to ask the medical oncologist. Is there any role of docetaxel in this setting? Is not there. Now, recent trials have shown benefit in overall adding docetaxel in high-risk prostate cancer, high-risk non-metastatic prostate cancer by these trials which were published in ASCO, which showed improved overall survival. So, but we need to know that sequencing of docetaxel for postgraduates, if we are giving docetaxel as well as radiation, as well as hormone therapy, the sequencing is important. Sequencing is like first we have to start androgen deprivation therapy, then within 12 weeks of starting androgen deprivation therapy, docetaxel to be added. Once docetaxel, and it takes 6 cycles, 75 milligrams per 6 cycles. After you complete docetaxel, then radiation to be started. That is the sequencing. Right?
No, I don't agree with that. I don't think there is a role in the neoadjuvant setting for docetaxel. Whatever that trial that you showed, the docetaxel was added after radiation in the adjuvant setting, not in the neoadjuvant setting.
But that trial was in high risk.
You mentioned that radiation after it is after
after chemotherapy. After, I mean, first chemotherapy, then radiation.
No, in this time I would look at that. whatever the trial is for chemotherapy in high risk after completion of radiation, not in the neoadjuvant setting.
I'll check that. This patient also he was planned for radiation up to that. Then I was supposed to ask how to plan the radiation of this prostate cancer. And how this was properly shown by sir, rectum emptying, bladder filling, everything. But one thing I wanted to ask is how frequently do we do CBCT, sir?
Daily. There is no shortcut. If you want urologists to come out of that era, first we have to come up with that. So there's nothing short of daily. There's no question, there's no compromise. If for any reason we are not able to do it, let's not give 76, let's give 79.
Let's not eat on that day.
How do we correct it, sir? How much? Any other if it is one
We won't have this rotational corrections, only translational.
So if you are doing daily imaging and if it is CBCT, then there is no issue of correction because correction is more distorted. So then the question of having a threshold in that situation doesn't arise. The threshold question is a golden question when there was a EPID based, IGRT we were doing. So that time because thresholds were required because you had to go inside to do the correction. So that time it was a valid question, but now it doesn't matter. Since if you're doing CBCT, then correction is automatic.
Hypofractionation, anybody is practicing this? Is there any difference between the selection for hypofractionation versus the conventional fraction?
So I mean for last 3 or 4 years. So this one which Karthik showed 70 gray 28 fractions. So that one I have found for all patients. And I started doing that. I had a down report high risk. But once Astro came out with the guideline, I started following that. So till now there is no difference.
So what's your comment on that versus 16?
No, 1620 also should be good. In fact, if you see from the founders paper, radiobiologically 1620 milder as compared to any other. So if you can follow others, I think 1620 should not be a problem. When I tried to choose which one to go for, I had some difficulty understanding the constraints which are given for chip. That's the reason I didn't follow. Whereas in this one, the constraints are straightforward.
So in terms of all the risk factors, like in high risk, intermediate risk, I followed 37.5, very long, almost more than 10 years, high risk and low. So I say 2060 probably like very, like once you start hyperfractionation, you will come to know, not a problem at all. The second point is there any margin change you are going to do it as per now? Like it's either is a conventional or hyperfractionation?
So now after we have this CBCT has come and with along with initials, now I have reduced the margin to 5. Yeah. And I have just now done one case of SBRT, so where I made it. So that I want to This I've done only one. So that particular patient, I'm not done any radiation, but this data, and especially this one, at least one paper I'm aware of Indian paper from data. And there are a few other papers which say that when you want to say 5 fraction, then he wants that things. So 25 in 5, for a global thing is safe. Actually, it's not a randomized data, not large number of patients, but good number of patients with a recent follow-up, so it does not cause differences.
So in these cases, when the hormones are giving only involved nodal RT along with the primary, so that you most of the times I follow like it's probably around 15-20 patients. Whole pelvic RT as a whole, probably I have not done for a long time. I just recommend I go with hormone treatment. No, I would practice whole pelvis only involved node plus this one. Same as a constant of oligometastasis.
No, I haven't practiced till now. So now we are considering whether with pop RT is worth doing it. But till now, I have not done.
This is already discussed what vaccination to be followed in this case. We have criteria for following chip trial kind of vaccination also. We should be T1B to T3A, and estimated cycle involvement should be less than or equal to 30%, and PSA less than or equal to 30. These patients were actually involved in chip trial. So I think in chip trial kind of vaccination, this should be followed. Also, Sir has explained about the property trial. We have conflicting evidence of involving prophylactic lymph node irradiation. Till now, it is not needed, but by property trial, they have again told that it should be done in very high risk and high risk. What is your comment on this?
As I said, one is not comfortable treating this pelvic nodal irradiation, at least because many times what I have seen two things. When we ask the PSM intensity, they say faintly avoid the nodes are present. Then I can't take a chance when the Gleason score is almost 8 and cycle infiltration is there. All the high risk features are the PSA is quite high. I generally include if there is any doubt that the lymph nodes are involved. I was also not including these lymph nodes quite some time back, and then I saw 2 or 3 patients coming with nodal recurrence in around 1.5 to 2 years. But then I see all these PSMA CT scan and the risk factors and take it out. And these days I have started including the nodal irradiation when the risk is high or if PSMA should even suspicious nodes.
So I risk and the PSMA average we should include nodal irradiation.
So the data is conflicting, but I'm including.
This patient received India with 74 with some fraction along with lymph node irradiation. When he was started on adjuvant hormone, I wanted to ask about Abiraterone, adding Abiraterone in this case. The NCCN guidelines says high risk.
Yes, the whole thing is shifted. So whatever we are doing metastatic has come in high risk now. So there is a role of chemotherapy, there is a role of double hormones from the beginning. So I don't know, the radiation oncologist actually, when we see all those things, with the first case when they did the surgery and give a post-op radiology, if you are selected as that as the first case for the radiation itself, we wouldn't have done anything and waited for 10 years. But now we are looking for an era where we are talking about just one factor of the PSA or the IRIS. We have shifted all our armamentarium to live primary, and they say survival advantage. It's well, and with the only RT alone, we would have like we have seen the results of one. So it's very conflicting as a whole. But yes, data is there. Whole thing is shifted to IRIS.
If I remember, the Abiraterone trial is a negative trial. Prostate cancer is not recommended in the adjuvant setting.
So not given the hormone plus Abiraterone combination they started instead of the chemo also.
But on what basis? As far as unless you can tell me that it's utterly wrong, I think it's a negative trial. It didn't show any benefit in the non-metastatic setting.
But Rajesh also when he presented, he was meaning that high risk also. And NCCN guideline also mentioned high risk cases Abiraterone can be added.
Probably in this is what Sharon said, a lot of investigations in genomics. So to identify, because on one hand we say it's slow growing, on one hand we say it is heterogeneous. Identify those who require high-end treatments. Probably those are the ones which should probably answer, get the answers in the future.
We should be careful in adding all these therapies for these patients. At this point of time, it is definitive in the sense 2 years, 3 years, the treatment ends. Once you go in this direction, it is lifelong. We are not considering the impact of that on the patients, cost, long-term toxicity, visits to the hospital. Actually, the life is quality of life is miserable for them. Yeah. So many of them are elderly. We have seen people, they have transport issues. There's nobody, to bring them to the hospital to get a PSA done and all those things. So we are, evidence is one, it's great, even if it is positive, but it is making people's life miserable. Like cervix patients, they get 2 weeks, 2 months treatment, and head and neck, it ends. Look at the other sides, lung, renal cells. We are heading in that direction. Yeah. If there is no robust evidence, see how much more we are going to improve. Present day times, we are looking at 85-90% kind of long term. How much more we are going to improve? At what cost? So I think, at least as radiation oncologists, we need to be careful.
These are all good treatment options for castrate-resistant prostate cancer. Use them upfront. Okay, now your options at that point start reducing, and you're literally pushing them into getting castrate-resistant.
Also, we are losing one of the options that we have to use in the metastatic. So the last question: after 1 year, the patient complained of erectile dysfunction. So could this have been prevented during radiation plan somehow? And are there any treatments available for erectile dysfunction?
Why you are blaming radiation? Why not stop radiation? First thing is stop hormone. That's what is bothering.
My actual question was, if we are using only radiation as a sole modality of treatment, is there anything we have to do to reduce the dose to $2 by hands to reduce the...
Most of them, they are on hormone. We don't give radiation alone. So this is because of hormone, and sildenafil option is always there for them.
It's preventable, though, has nothing to do with erectile dysfunction. That's all. That's all. Thanks. Thank you, Dr. Rupesh, for the panel discussion. I call upon Dr. Saurabh to deliver the vote of thanks.
Any questions in the report?
No, sir. No. Should I not do any questions now?
Thank you. We just put it. I have one question. Where is the dinner?
Yes, sir.
Right after this.
Discussion was very good. I will give 5 on 5. I enjoyed it. So this just especially for the postgraduate students who are offline and online, we are conducting a workshop on 5th and 6th of February. That will be Saturday and Sunday on cervical cancer. We have title leaders from conventional to conformal. The highlights of that would be it's cadaveric based hands-on experience where you can put the applicators in the cadavers and practice. Second one, we are planning to get system for each one of the postgraduates so that you can do the contouring, and we'll also have a poster presentation. And the most important thing is we'll have experts who will be giving their words of wisdom at every level. So I'm sure you'll be benefited. So please contact Dr. Deepika Lavanya, and these are the numbers and the mail ID. Thank you so much. Looking forward to seeing you.
Thank you, everyone. I'd like to thank the organizing committee for giving me this opportunity for delivering the vote of thanks. But I think it was a good gathering in spite of the situation. Close to 40 people have come to the hall in this hybrid kind of conference, and 60 people have joined online. A total of 100, quite a good number. I think I should congratulate you. Very good coverage of all the topics concerning prostate cancer, especially with radiation oncologists. And I'd like to thank Dr. Krishna Sharan from KMC Manipur, Dr. Radhesham sir from HCG, Dr. Karthik from Shankara Cancer Center, Dr. Vadiraj from Manipur, Bangalore, and Rupesh for winding up with a very interactive session. I'd like to thank Ferring Pharmaceuticals for sponsoring the event. And everybody, the dinner is organized at ground floor.
And online people also come to join for that.
Thank you, thank you.
Anyways, you may put on the.
I want to tell you about this workshop which is organized in Ramay. I was one of the first students who has attended it. It's a wonderful session and I think everybody has to do it.
Thank you.